but make use of those minutes. Okay, observe everything which is shown in the video. If there's a SATs monitor, okay, everything that is there in the video you should explain. Okay, so don't just simply jump. Explain whatever you see in that video. Okay.
Yeah, sure.
Yeah, so you've seen the video. Do you want to comment? Do you want to start? So the questions will be explain what you have seen, and what are your differential diagnosis, and what have you and which conditions, where do you find these signs, and how would you manage?
I've seen a 30-second clip, a video of a baby, being a 1-year-old child being examined, being auscultated. This is a cardiovascular examination of a 1-year-old baby who looks well, pink, well perfused. The baby has a pacifier in the mouth and is being held by a parent. The initial examination starts in the chest, at the aortic area, and followed by an auscultation in the carotid area. I can hear an ejection systolic murmur in the aortic area, and a loud S2. This murmur is radiated to the to the carotid area on the left side, which can be appreciated by auscultation on the left carotid area. The child looks well. There are no other aids like oxygen requirement or any other needs of support. He looks well in himself, and he's trying to push away the stethoscope, which shows that he's well in himself. There are no signs of respiratory distress. There might be some mild intercostal recession in the subcostal recession. There is no distress as such. There is no work of breathing. He looks well, pink and well perfused.
So in this video, there's a 1-year-old child who's seated on the lap and appears to be and is alert and crying and appears to be warm and well perfused. An auscultation of the chest is done, and when the stethoscope is placed on the right side of the chest, a holosystolic or a continuous murmur of grade 5 in intensity is heard, which is also radiating to the neck area when the stethoscope is placed on the neck region. The child also appeared to be breathing heavily, suggesting of tachypnea.
Yeah.
Okay, so what are your differential diagnoses, and what do you think this murmur is, and this murmur is arising from?
Yeah, this looks like because this is ejection systolic. I'm assuming this is ejection systolic. It could be an aortic stenosis in a 1-year-old.
Okay.
And with the radiation to the carotid. And we will investigate with further with taking the blood pressure, the pulse, basically the vitals. I would like to also do the chart his height and weight with age appropriate and gender appropriate charts. I would like to take his vitals, including pulse, and look for all the pulses.
Okay.
I would like to also measure the blood pressure, colon blood pressure, and look for pre and post SATs as well. In terms of investigation, I would like to do an ECG, echo, and and look for any peripheral signs. Yeah.
Okay. But as you described, Harshada, that is fine. That is listen, you have looked at this video clip where you have got a young infant who is well, although he's crying, but he's responding appropriate to the stimulus. He appears to be pink and well perfused. Uh, uh, I have some doubts regarding this video. If it is a recording issue, I mean, in terms of if the image is inverted, but looking at the video, the auscultation is being done on the right side of the chest. It's not on the left side of the. Did you appreciate that? Hmm? So the stethoscope was placed on the right side of the chest. It was not placed on any particular any particular cardiac lower left sternal border or apical area or segment first to right to left. So I would go with this video because the auscultation was done on the right side of the chest. It was just placed on a precordial area, and what I could hear murmur was a continuous harsh blowing murmur of grade 5, at least grade 4 to 5, harsh blowing murmur.
Did you think it was a VSD murmur? Because I have not been able to listen to this, and I have now confused all the murmurs that I heard.
I think it's a continuous murmur with a harsh blowing character, with a machinery murmur. Do you know? Have you heard machinery murmur?
Yeah.
Yeah, so it is more of a continuous murmur. I don't think it has got a separate systolic and diastolic component. It is present throughout the heart sound. It is present in the S1 and S2 and beyond that. So it's not having any kind of either ejection systolic or a pansystolic in nature. It is present even in the diastolic component, and it's got a very quite characteristic harsh billowing murmur kind of thing. So I would comment it to be a continuous murmur with a grade 5, not grade 6, because when the stethoscope was taken away, the murmur was not heard. But when the stethoscope was put, the murmur was loud and clear, and it was quite harsh blowing kind of consistency. So it is grade 5 continuous murmur heard over the precordium radiating to the left carotid area, which is inconsistent with a PDA murmur with a dextrocardia. Okay.
Which is consistent with the PDA, you said, huh?
Which is consistent with a dextrocardia and PDA. The reason I am saying dextrocardia is because the auscultation was done on the right side of the chest in the video. Did you appreciate that?
Yeah.
And ideally, the auscultation should have been done on the other side of the chest to make to make it more clear that it's the murmur is heard or it's less on the other side of the chest. So that would have been that would have given away the diagnosis. But I also, so when you get a video like this and when you're seeing it's being done on the right side, it is more than likely to be a dextrocardia, and the character of the murmur is a continuous murmur of consistent with the PDA or a and the other causes where you can get a continuous murmur. Do you know where are the other causes where you can find continuous murmurs?
You can find them on what do you call that? Yeah, for dialysis.
AV.
So the other conditions are AV malformations along with PDA, and then you can also have BT shunts post-operatively, which is quite common, and it can radiate even to the back as well.
Severity, the grade 5 can radiate all over the precordium, but it would best be heard in the it would best be heard in the second upper left, second intercostal space, or the
go on.
Yeah. Even the aortic regurgitation murmurs can radiate to the carotid, and then you've got the continuous murmur can, as I mentioned, can radiate to the carotid, and then you've got aortic stenosis, which you initially pointed out that classically radiates to the carotid. So these you can get it, and don't get biased by just because it's going to the carotid, it has to be this and that. It has to be this particular murmur, because the murmur which you heard was clearly. And
Continuous format.
yeah, and I just have a feeling that the video, uh,
Very
the
clear,
recording,
isn't it?
the video is not clear,
Yeah.
but the it seems to be inverted. My concern is that the original video would have been that the auscultation is happening on the left side of the chest where actually the heart is, and when someone recorded the video or screen recorded or put the file on the Google Drive, and it just got inverted, and it happens with a lot of videos. But regardless, in this, going by this video, the auscultation is happening on the right side of the chest.
Yeah.
Okay,
Yeah.
so it is you have to make that point, um, which is quite significant finding in this video. So the important findings in this video are that the child is alert and well, and it looks like an infant who is crying, responding appropriately to being handled, and for his age, and then he appears pink and well perfused. This is the general description, and the auscultation is being done on the right side of the chest, which is a key finding here. I've heard a lot of discussions in other groups where they are discussing among themselves, and they try to describe each and everything, sometimes useless things in the video, that the child is sitting in the bed sheet is white and the pillow is black, and they put everything that is
Time
seen in
wasted
the,
के लिए.
yeah, they put everything which is seen in the frame. So avoid those mistakes. Stick to the
I
relevant.
didn't do that. Yeah, I didn't do that.
No. I'm just telling you as a side point. I have
Yeah,
seen this
yeah.
discussion, and I've also had the same reaction, and it's just it's just silly. It's quite silly for grown up doctors to discuss like this. And then yeah, I think I mean, don't take offense, but again, a similar alluding to this, your description was that there's a pacifier in his mouth. It was not required.
Uh, okay,
You
okay, okay.
understand? Yeah. So
Yeah, yeah.
yeah. So I mean, those things are that will take your time. That will be time wasting, and make sure you. Yeah, there are a few things which are inconspicuous, which are like not quite obvious. Like if there's a catheter hanging somewhere, if there's
Yeah,
if there's an NG tube, and
yeah.
those things need to be mentioned. Okay.
Got it.
I just want. I'm sorry for joining. I just got what do you say, cut off.
So here Dr. Saleh presents another example of a case, how to describe and what are the relevance points which needs to be put in your
What do you
description.
say? Mastitis. Okay, so had a cannula and
Mastoiditis is it, right?
mastitis. Yeah, red preauricular
Inflamed.
swelling
Yeah.
in the back of the neck, back of the
Mm,
ear. Yeah. So
mm,
he basically you need to describe what all you saw. The child has a cannula, and they
mm,
show the temperature in the child. Yeah.
mm,
And it was very fiery red. So you describe that, so you can just say, I suspect this could be a case of mastitis. And then they will ask you, like, why do you think it is mastitis? So you say, and then who all will you involve in the management, like, ENT, then would you do a CT, things of that
mhm,
sort. Yeah.
mm, mm,
And
mm,
he even asked me, is there any CNS complication of mastitis? So I even said, like, grade Nigo syndrome, like lateral rectus palsy. So that yeah,
mm, mm,
yeah. So we can do more video stations later on. Yeah.
mm.
And that'll give you an analysis. So you just look at how the gait is. Sometimes they might want you to look at everything, whatever is shown in the video. So take your time, look everything in the surroundings, and yeah. And the dummy pacifier was not needed. Oh, that is not relevant here. Anyways, okay. I just wanted to add
No,
that.
no. Yeah, I've listened to other groups where candidates are discussing among themselves, like there's no one mentoring, but and then I could hear them describing things which are completely irrelevant. That this is in this clinic, this is in this kind of setting. The child is on the bed, which is a white bed, and things like that. And I've so and candidates, they do tend to pick up and focus on things which are not necessary, and they miss out the more important and the relevant findings. And when it and broadly speaking, in a video station, you would be getting videos in the topics of respiratory. There will be one respiratory, either it could be a barking cough or bronchiolitis or an asthma or things like that, and the differential diagnosis will be in the same lines. And one of the questions they might ask you, that would you do an X-ray, and the X-ray will not be required usually. For example, an asthma child coming in asthma exacerbation, and they will ask you, would you do an X-ray? The child coming in with the bronchiolitis, and then you would in your management plan, you will not be commenting on doing an X-ray. So they want to check you how reasonable you are with your management. You're not going overboard, and you're not missing out important things as well at the same time. So, and the other category of the videos are procedures or maneuvers, and these could be an SVT resolution by a ice pack or a adenosine being given, and you can see a resolution of the SVT, sorry. And then you can also have procedures like long line insertions or lumbar puncture being done, and they would ask you what space do you do, what are the indications, and things like that.
And all
And
types of catheters like peritoneal dialysis catheter, VAS cath, they can be kept. So you need to recognize what is what. Yeah. So then Mitrotinov, there's a bladder augmentation surgery, some Mitrotinov surgery. So scars could be in the hypogastric region. What kind of a scar it is? Yeah. So yeah, ureterostomies, things like that. Just broadly say you think this is this, but I would want to keep a differential of this and this and this, like that. You should say if you're not sure.
Right.
Yeah, and then you've got respiratory, then maneuvers, and then you will also get factitious illnesses, and mental health, and neonatal stuff, like the baby who is again a jaundice baby, like prolonged jaundice, who's had Kasai's of a procedure. Those aspects where they are not able to assess you in the other clinical domains, they try to put it in the video stations. Okay. Or a skin rash, a child with staphylococcal syndrome, a staphylococcal scalded skin syndrome, a child with epidermolysis, generalized epidermolysis bullosa, and things like that. So these are the domains that you need to be you bear in mind while preparing for a video station. Okay. So if do you want me to do the other video, the number 10?
Yeah, we can do it. Only thing is the audio nahi aa raha hai for some reason. We can try.
Yeah, I will just.
Or does Dr. Safia want to do?
Yeah.
Let me.
I will try.
Are you able to see my screen?
I can see.
Yeah, I'll just play the. Yeah. Were you able to hear and see the video at the same time?
I did. I'm not really sure if I heard correctly, but I heard something.
Fine. So yeah, would you be able to would you make an attempt to describe what did you hear, and what were your impression, and what?
Yeah. Well, the child looked to me well perfused. I could see that there was a scar in the midline, around about the lower sternal border. There was a small scar. And regarding the sound, I thought I could hear. Maybe, I think it was an ejection systolic murmur. It was loudest, I think, in the apex of the probably at the apex of the heart, and it was
maybe the quality of I think it was around about 3/6.
Okay.
Yes.
So what do you think the scar is from, and what do you think the murmur is arising from?
I think that it is arising from the mitral valve. Maybe it is the mitral valve prolapse, because I thought I could hear a clicking sound as well. I'm not sure if that's correct, but
Okay.
yeah.
So what is your impression about the scar and the what condition would do you think the murmur is will be present? In which heart conditions would you think the murmur will be present?
Well, I'm not really sure about scar. Probably a procedure to insert probably a stent, and I think maybe the child probably has rheumatic heart disease. Maybe the child also has maybe Marfan syndrome. Um, I'm not getting anything.
Okay. Do you want me to give you the feedback?
Yes.
Or do you want to end, or do you want to make any? Do you have any questions before that?
No, I don't. Actually, I'm starting new, so I'm sorry if I'm very bad at it. I would like a feedback, please.
Don't worry.
Don't worry about it. But I mean, just to give you if we are able to give you a point to start how to prepare, I think that should be a good place to for you to start preparing, and then that would be helpful for both of us. So I mean, it could be the video quality, but I couldn't appreciate any scar in the video. I didn't appreciate any midline scar or mid stenotomy scar. But even if you and that should be, it should be quite clear in the video. I will send you the link and go through it again. But in your actual exam, this is not something which is a matter of dispute. If there's a scar, it's not going to be subjective. It will be very objective. That means it is there or it's not there. So I mean, just giving that discount in our discussion here, it could be the video quality that I'm sharing over the screen, and that could be adding to the artifact kind of thing. But there was no scar I could appreciate. However, if you do find a scar, if there's a child with scar in the midline, so you have to be well aware of the types of scars on the chest, and you have to name those scars, like it's a midline sternotomy scar, or it's a lateral thoracotomy scar, or it's um, infraclavicular scar. So each of these scars have a background relevant information for what procedure these might would have been done. So open midline sternotomy scar indicates an open chest surgery for a complex congenital heart disease and procedure. A stent is not usually put through a midline scar.
Okay.
Okay. It can be done through intervention through a radial artery from femoral or a radial femoral artery. Usually in children it's a femoral artery, or it can be done through lateral thoracotomy scars. And the lateral thoracotomy scars give you access for the placing the stents, repairing a PDA, repairing a coact. So these are the and also lobectomies. Okay, so there's a good list of contents in PDF I can share with you for the relevance of scar. Coming to the murmur, my impression of this murmur was the classic pansystolic murmur, which was heard in the lower left sternal border. So in the description of the video, it is you should start with this. So there was 18 months old indication on the right corner of the video. So you can say it's an 18-month-old child being examined, assessment of the cardiovascular system. The auscultation findings were. Harshada, are you saying something? Hello, Harshada, are you saying something?
Go now. Yeah, I have to go
Fine,
now.
fine. We'll send you the recording, and you can come back if you wish. Okay.
Yeah, sure.
So, coming to the murmur in this video, I'll again you have a listen at it again. So my impression was it was a clear pansystolic murmur being, so it was a child, 18-month-old child having a cardiovascular assessment with the auscultation findings, auscultation being done in the lower left sternal border and the mitral area. Okay, so and the way this is the way the in the UK exam format or the Wayne, if you read the Wayne Harris, they don't describe tricuspid area or the mitral area or aortic or pulmonary area. What they describe is lower left sternal border and then the apical area and then the second intercostal space right, second intercostal space left. Okay, so they don't name the walls because the walls can be at different places. So I mean, I'm just giving you an ideal or the right way to describe what you see even in your cardiovascular station, in your clinical station. If you do get a cardiovascular assessment, this is how you would be naming the areas. So in this particular video, there was auscultation of the lower left sternal border and the apical area, which was and the murmur heard was I could hear S1, S2, and the murmur heard was pansystolic murmur. Best heard in the lower left sternal border, which is in keeping with a VSD murmur. Okay, so 18-month-old child, warm, well perfused, appears pink and alert and awake, having auscultation, cardiovascular assessment by auscultation, and being done in the lower left sternal border, apical area, and the type of murmur you have heard is the pansystolic, grade 3 to 4 out of 6. And then
Dr. Safia,
Yeah.
yeah, just understand. Okay, these video stations, right? There is something very obvious in the video. Nothing will be kept hidden. Okay. So don't like 18-month-old in the and it'll be something which is quite common in the UK as well. Okay, so don't mention like rheumatic.
Yeah, that
keep
was my other point.
yeah. Okay. And mention that if you think it's a Marfan's something, it will be obvious Marfanoid. They will show Marfanoid facies and then they want you to assess what kind of a murmur it could be. They will show you a Marfanoid habitus, a long, lengthy, and a teenage and an adolescent, and then they will show you a murmur. Okay, so nothing will be very hidden. Things will be very obvious.
Yeah.
Okay. Yeah.
So exactly. That was my next point. A rheumatic heart disease is very unlikely. It's not seen at this age group. It's more of a teenager, and after the child has had an episode of post-streptococcal involvement of the heart. So don't avoid mentioning those things. Otherwise, that will that can give you negative marks, kind of. I mean, the examiner will score you less on the clinical reasoning, and you will lose marks in those domains. So simple VSD, and in the management, what you will do is you will get an ECG. You will discuss with the pediatric cardiologist. You will arrange for an echo. You will assess in your clinical findings. You will do a complete examination, assess and rule out any heart failure, possible heart failure, any infective endocarditis, and then you would assess for nutrition as well, and then that's it mainly, and you will escalate it to your consultant and pediatric cardiology. Okay. So this is what they basically expect out of you in your clinical exams. So if you could, if you probably
should we do? There's Maham. Dr. Maham has joined. Should we do one last video for Dr. Maham? Is there a video?
Yeah, 1 second. 10, 11. I want to do something else apart from cardiac. Let me see if I can see something.
Dr. Safia, hope these sessions have been helpful for you.
Yes.
You start. Are you taking the October exam?
Yes.
Oh, okay. So you tell us what you want, and we can organize sessions accordingly. Okay.
Oh, okay.
Yeah.
At the moment, I think everything is useful that you're doing. Even the last session that you did of the neurology, also very good. I really appreciated that one as well.
So see, join the group, and then you can tag along with Dr. Harshida or Dr. Ubaid, or there are so many people in the group. So find, speak with them, and then do sessions if you want to just practice with them as well. Yeah, or else just let us know, because yeah. Okay. Have you worked in the UK before, Dr. Safia?
That's no. Unfortunately, I haven't worked here. That's the issue.
Okay. That's fine. That's fine.
Um,
Dr. Maham?
Yes, Dr. Saleh, Assalamu
Oh,
alaikum.
walaikum salam. How are you? You okay?
I'm good. Yes, how are you?
You're good. Okay. So Dr. Raiz will do a session. Okay, video.
Thank you so much.
Video. Look into the. There's a preparation time, so use that preparation
So,
time.
yeah, were you able to appreciate it,
yes,
or do you want me to play it again?
yes, but I appreciate, I think, so there is neck stiffness.
Uh, Fine. I'll play it again 1 second. Try to.
Myself and then do. I don't know how to pray.
No, that's fine. No problem. I can. If someone wants to make an attempt, that's fine. Otherwise, I can do. It's a bit tricky. It's a bit challenging video. It's not a simple or straightforward
Want to
one.
do it?
Do you want to do it, Harshida?
Yeah, I'll give it a try.
Yeah.
Mm. Okay, I couldn't see the age of the baby child, but this was
Yeah, it's a
probably a
toddler. It's a toddler age group. You can say there was no age mentioned. That's it.
okay. So this is around a 30-minute clip. I was just shown a 30-minute clip, second clip rather, and I can see a toddler being examined. He looks irritable and he's crying. He's being examined on the bed. He looks being well perfused. Um, he seems to have some syndromic or dysmorphic features. Um, um, in terms of, I think his broad-based nose and his mouth, I think he had peg-shaped teeth, and he looked well perfused, not in distress, but he was crying profusely and probably showing flexospasm of the upper trunk of the upper body. Um, uh, so this could be any epileptic syndromes. Uh, l- uh, and most probably one of those, I think probably those Linus Gestalt and things. I'm not sure. Um, yeah.
Um. Fine. I'll try to play the video again because I
Different findings though. For me, can I say it?
yeah, make it
It was
go.
for me. I feel like there was angioedema. There was swelling of the lips and swelling of the upper eyelids, and the child was very irritable. And I felt like his face was also very flushed. That for me, maybe it was like maybe an allergic reaction, something like that.
Okay, and so I would then I mean you're right. I agree with you. And then I would ask you
It looked like Kawasaki's to me.
what phenomena did you observe when the child cried?
Like he was getting even more red, like that.
You are partially right. Um, so this is basically it's a simple video. There's no I mean the dysmorphisms, and there's no uh, if those things are not quite obvious, again try to avoid mentioning those things. It's a normal child with normal lips. Just I mean you can mention a bit of edema with the lips, which can be due to crying, which can be due to an allergic response. But essentially it's a breath holding spell due to crying, and the child being blue, the child turning blue because of crying, because of that breath holding spell. And when the child was seated upright and tried to pacify it and calm down, the lips got its color back after that.
Where was the blue? Sorry, I didn't see the blue. Just the blue.
The around the extremities, if you look at the hands and the lips, it turns slightly dark. So it's more of a breath holding spell and leading to that cyanosis. Let me see to share it once
Hey,
again.
replay.
I'll replay it once again.
Yes, now it is coming.
Yeah. And sometimes the videos are like this, which are quite straightforward, and you don't need to. It's not very evident or clear. Look at the hands. Look at the lips. Look at the lips.
The limbs you said, yeah?
Lips, and the extremities, the hands.
Okay. So when he's up, it is quite pink.
Yeah, it's quite
It's very
pink now.
difficult to look.
It's quite pink
Yeah.
now.
Very
Here it was a bit dark initially.
The tongue looks very purple.
Yeah, that purplish thing is that's what I'm talking about. It's the cyanosis that's going on. The brief breath holding. So it is a very normal child who is just crying, a normal toddler who is just in discomfort or whatever. He's crying and he's having a breath holding spell where his lips and his extremities turn a bit dark in color or purple in color, and then it returns back to being pink in color. And that's mainly it. And then they would ask you what is a breath holding spell, what is a cyanotic spell. The discussion will go there, and how would you manage those things, and what are the types of breath holding spells. So I mean, when I was preparing for the video stations, these are the tricky things. We tend to over medicalize. We tend to overthink very rare things, going into completely different tangent, but it is something right in front of our eyes, which is quite simple, plain and simple. And just comment on what is being seen instead of inferring things. Um, First comment on what you have seen and what is being shown in the video. Of clinical
Maybe
relevance, of course.
maybe in the video, if there was audio, right, we could have almost like got a little more idea as
Yeah.
that it's that's holding. So there will be audio, so things will be very obvious. Don't worry, okay. And these sessions make as much mistakes as possible, so it's fine. Just so that you get an idea of how things will be for the real exam. So that's what the basic agenda of these sessions is, to make you guys make as much mistakes so that you can have a clear mindset when you go into the exam. Okay, so when there is audio, I feel you'll get it. The child would have breath holding. You would have got a more complete picture.
Yeah, I will try to share this file in the group, this video in the group, and you can go through it again. It's not a rocket science. I mean, because once you know it, then you will have to just be prepared with your cyanotic spells and breath holding spells and the causes and how will you manage it. So the way you will summarize this is I see a child in a toddler age group who is being pacified, who is crying, and I could note that his lips and his fingers were slightly dusky when he was crying, and he had a brief breath holding spell, and then it turned pink later on after pacifying. So I think this is a breath holding spell, a brief breath holding spell, which is a benign thing for children to have, and they outgrow it and then they will ask you how would you manage this? It's mainly reassurance.
And tell about
then,
iron deficiency anemia, which is
Yeah.
seen along with the breath holding spells.
Yeah, and then they may the questions might also go, what are the other causes where you can see cyanotic child turning having cyanotic spells. Then you will list your other causes like a cyanotic heart disease, like a TOF, where they can have a cyanotic blue spells, where they and that's managed with knee folding position and then giving morphine and sedating and calming the child, and then so that's a different line of management. But the discussion can go there. Okay, and if you in your mind, if it comes like unusual and rare things, for example, Safia, in your previous discussion you mentioned Marsonoid, and and in your discussion, Harshada, you mentioned that they were peg-like teeth and things like that. Those are quite I mean, in itself a big medical condition that if they have to keep it in the video station, they will make it quite obvious, as Dr. Saleh rightly pointed out earlier, that that will be the striking feature. You will not be able to pick those things as an indirect thing, like something else is happening. The child is crying, and you are picking a peg-shaped teeth for suggesting of neuromigrational disorders. So those are
Ectodermal dysplasia.
Yeah, ectodermal dysplasia. So those are bigger things that. So try to apply your presence of mind that they are unlikely to be asking me this in this particular video for something a rare syndrome in this video. Those things are, they want it to be quite obvious, to make it easy for the candidates, and that's what make the video station quite easy and quite tricky for a lot of candidates. So it can be, people can go in complete different tangent, or people can just make score full out of full marks in this one.
More often than not, it'll be a simple station, not a complex one.
Yeah. Very simple station, and quite obvious what's going on. And for example, in this instance, the child's hands were getting dusky. Those things are small things that can be missed, but you will not be losing the station completely based on that. But if you do point out, you'll get extra marks. Yeah.
One thing I've noticed, right, in this station, there's something obvious. There is something obvious they want to portray, and you have to pick it up, and the discussion will go in that way. So as Dr. Rai said, if you go tangentially wrong, then they won't be able to bring you to that discussion. Okay, they want to show you something, and they want to discuss regarding that issue. Okay, so when I lost in my first exam, there was a post-cerebralitis cerebellar ataxia. Post varicella cerebellar ataxia. Okay. So if I say some other gate and I don't say cerebellar ataxia, they will not be able to give marks to me, because they want to discuss, will you do an MRI for this? So they want to get some answers out of you by showing you a particular video. So if you go wrong, that is why many times, you might lose a lot of marks in the station because you tangentially went wrong. Okay, there is something very obvious, and you have to pick it up. If you pick it up, you will get very good marks in the station. Okay,
is a 12 to 13-year-old girl who is. So the video starts with a 12, 13-year-old girl who's standing in front of the screen. In a very, you can clearly make out that she's in a low mood, like she's not happy looking. Okay, and she's in shorts, in trunks, and her upper t-shirt is raised up, exposing her abdomen area, and then the video zooms into her abdomen. You can see some red marks in her abdomen, and then it goes to the back, some another red marks, similar ones, and then the video zooms out, and then again you see that girl who's quite listless. I mean, displaying, illustrating no emotions at all, and does not. You can make out that the mood is quite low for her, and that's it.
Like
That
an
was the
apathy.
video, and it closes there.
Apathy.
Yeah, and yeah, it was the. So what do you guys think that could be?
It seems like she's
The
like
red mark.
steroid or something.
Sorry,
Maybe
say again.
she's a depressed patient and dry. So this seems like there is excess of um, cortisol. Maybe she's a Cushing syndrome patient, or maybe she is a patient of PCOS or something like that.
No, what makes
The
you
red
think Cushing
marks
syndrome
are
or PCOS?
Because she has abdominal striae, and she is also very
No,
depressed.
so yeah, that's the marks which I'm describing is not a stripe. It's not a linear mark. It's just a irregular patches of red marks,
the
which
abdomen and
is
the back.
and then few of those marks at the back as well, which
So
is
it could be
which
somebody with
I mean I will say out the answer, but it looks when you see that video, it will look more like not fitting in any pattern or shape. It looks more like a bruise marks, reddish
Self
bruise.
harm
so it could be a branding, or maybe she's trying to
or
use
abuse.
something to comfort herself with pain. Maybe she's suffering from chronic pain, and she's using those hot packs and things, which is not helping her.
Yeah, so it is a simple and um, it's quite a simple one where you have a 12-year-old child with low mood. You will be describing what you have seen, a 12-year-old child with low mood and some marks on her abdomen and on the back, which is more likely to be a bruise marks, and that could be secondary to self-harm or abuse like love bites and things like that. So this is where they wanted the discussion to go on in the mental health aspect of adolescent, especially the age
Safeguarding.
of the girl and her mood and those marks. So that's what the video was about.
This is all safeguarding. That it will go into
Yeah,
safeguarding.
you will involve the safeguarding, you will involve social services in your management plan. But before that, you will have to list what you're thinking of. Yeah, you're thinking of a girl with mental health issues with possible self-harm or sexual abuse.
Did they ask us for differential diagnosis, or did they just want like one thing and
No,
they
no,
give?
no. They usually ask you for differential diagnosis. In very rare instances where there can be no differential diagnosis, it's quite obvious, it's quite evident. It's just one diagnosis. You will just list you out that one diagnosis. But in most of the cases, they would want your differential diagnosis. There's a question specifically. What are the differential diagnoses?
How many do they usually like? For example,
Three.
three
Three.
patients or
They expect three at least.
three at least.
Three in the order of relevance. So if you see a child with barking, cough, you will have to provide at least 2 to 3 differential diagnoses. If you see a child who's coughing incessantly, so there you can list bronchiolitis, laryngotracheal bronchitis, or foreign body obstruction based on the age of the child. So that's what they're expecting. Is that all right? Any questions?
No,
Hello?
I think we just need to practice a lot.
Yes, exactly.
Sorry?
It means
I
a
think
lot
we
of
just need to practice a lot
yeah.
Yeah,
because
just
we are going all over the place.
try to I mean avoid going in two different tangents. One is one extreme is going in completely irrelevant
aspects of non-medical things and describing unnecessary things, or going into completely extreme of describing a rare stuff, which is completely off the topic. So try to get a balance between that, and the way you can do is see videos or these files which you have shared, Harshada. That's really nice, nice file. So if you could kindly share it in the group as well. Try to see one or two videos every day, either when you're having your a tea, coffee, lunch, whatever. See the videos and try to describe it to yourself, so that you are used to you're training your brain to comment on what you're seeing, and avoid going in the two extremes which we just mentioned.
Yeah.
Okay.
Keep an open mind before you enter the station. Keep an open mind. Okay.